You've spent over 2 decades delivering babies
Yes.
and managing women's hormone crash.
So when a woman sits across the table with you in your clinic, what do they come for?
Bleeding problems, period, heavy bleeding, less bleeding, vaginal dryness, recurrent UTIs, painful intercourse.
We would love to go deeper into HRT so that everyone hears the positive side of
Right.
HRT, because right now it's all negative.
Yeah. You have a lesser chance of dying from breast cancer. The risk of osteoporosis goes down, the risk of heart disease goes down, the risk of colon cancer goes down, the risk of dementia goes down. So it's also having many positive effects on the woman apart from just managing the symptoms.
That is a shocker.
How much does this entire thing typically cost? People feel that it's going to cost a fortune.
But it would be something around.
Dr. Amaya Kulkarni,
Yeah.
really excited
Me
to
too,
be
me
having
too.
this conversation today with you, and I think it's going to benefit so many
So
women.
We've actually done a couple of episodes, which she's done mainly, on perimenopause and menopause and things.
More symptom discussion.
Very symptom discussions, and a lot of comments that we received were, when do you get a specialist to talk about this in detail and hormone replacement therapy and everything? So I'm so glad that we'll be answering a lot of those questions today.
Absolutely.
But again, that beginning with what are the symptoms, that
Correct.
awareness is also
Yes.
something that's really
Exactly.
important.
And also, I think where I am right now, including myself, was surrounded by women of this age, right? So there's so many questions. I'm sure even you are surrounded by, including your wife.
Yeah, of
You
course.
know, probably in some years she will also get
Even
there.
right
So
now, she has questions, as in with respect to her health,
unanswered,
and sometimes at the back of her mind, is it perimenopause?
Correct.
She's in that age, right? So
And that's a common, again, misconception sometimes, when I had told my friend, I'm dealing with menopausal women. Acha, matlab older women, na, in 60s. I was like, no.
No.
That is
khatam ho gaya.
khatam ho gaya. So people are very, and then I said, no, the target, like it starts from 35. 35, so early. So
That
people,
is the first
Correct.
shocker.
yeah.
Exactly.
That is a shocker. And that is shocked so many people that even at 32, they're coming and asking me, I'm feeling this. Do you think? I'm like, wait, you're just 32, just chill.
Maybe it's not, it's just something else,
yeah.
But you've spent like over close to 2 decades or probably more.
A lot more.
At two ends, right?
Yeah,
One is
that way, yes,
delivering
yes.
babies,
Yes.
and the other is managing, women's hormone
Yeah.
crash.
So this end and that end.
Yeah.
Kind of a thing.
What is it like? Because there aren't, it's either, single specialists. There aren't too many people who are managing both ends.
Yeah. So, I mean, if you ask me that, okay, stop delivering babies and just do menopause, I'll say no. I really want to hold those teeny tiny ones in my hand. It's a very nice, whole experience. In the beginning, I took up gynaecologist for that experience. People are going to come in the hospital happy, I'm going to leave the hospital happy. So it's not a sad part of medicine, it's a happy part of medicine. But the satisfaction that I get by, delivering babies and all, it's a similar satisfaction when a woman who's been suffering through from all of these symptoms, and she's, I'm at my wit's end, and then she, takes the whatever treatment management, and she's like, now I'm feeling good. So that change in that quality of life, it really makes a difference. And that is where science has, or medicine has not been focusing on. It's always the reproductive age group of women that has always had the focus. All the studies, research, everything is, on that reproductive age group. So now when we are moving on, and the whole world is moving on to a little elderly age group, and the whole population is shifting that way, I think that the shift of medicine from just reproduction to other things in a woman's life, she's not
Exactly.
ending her life at reproduction.
Yeah.
So somebody looking at her after that, it's something really
At one point, nature tells you you can stop reproduction, and that's this phase basically.
exactly
Right?
exactly.
Yeah. I mean, I think we as women, every decade we have a new phase.
Really
Every decade. And this is what I've understood now. 1 to 10, 11 to 20, 21 to 30.
Right,
Every decade is different.
absolutely.
Yeah.
So when a woman, let's say in her 40s, sits across the table with you in your clinic, what are they usually there for? What are those symptoms, and what do they come for?
Rishabh, this question, if you would have asked me maybe 7-8 years before, I would have said she comes for bleeding problems, period, heavy bleeding, less bleeding, frequent bleeding, whatever. Those were the main concerns that she used to come with. Now, with the increasing awareness, now people do come and say, okay, I think I'm having menopausal symptoms, perimenopausal symptoms. But this is still, I would say, what, 0.1% of the population. Typically, still, these 40 plus women would visit a gynae only if they're having changes or issues with their periods. Then if you actually ask them leading questions, ki, are you feeling hot? Is your mood okay? Are you feeling very tired? Then they say, yeah, I'm having all of these symptoms as well. But that's not very often the symptom they will go and talk to a gynaec for. So when I started Elda Health, when we started that time, I had spoken to a senior army gynaec, retired army gynaec. Uncle, you have seen patients for the last 40 years. So have you had a patient coming and telling you, doctor, I'm having hot flashes, treat me? It's like not a single patient. Everybody is just coming for the period issues. That's when they really have to see a gynaec.
Correct.
And it's not because the hot flashes or the moods or whatever is not, bothering her. She doesn't know that I can talk to my gynaec for this and I can have a solution for that. It's like, this is a part of, aging, part of whatever, menopausal transition. So this is going to happen. That's what everybody has been telling her. If she goes and asks her elder sister, her mother, they'll say, period band ho raha na, this time, this can happen around that time. That's it. Nobody tells her that, yes, this is something you can go and talk to somebody and get a solution for that.
Correct.
Things are changing very slowly, but they are.
Yeah. But then just for the audience, right? Like, because we have done a symptom and all of that 101. But if someone's missed that episode and if they're just watching this, we would love for you to very briefly say, what is that journey like? Because everyone talks about menopause, right? That journey from perimenopause is a long one.
Exactly.
So quickly, just please.
So, the average age of menopause all over the world, 51 years. Average age of menopause for Indian women is 46 years.
Right.
Perimenopause, that is the changes when the hormonal fluctuations begin. That can begin about for some women 4 years, for some women even 10 years before they actually reach their menopause.
So anytime after like 35, 36.
So yes. So those symptoms can start from that time onwards. And it's not just period changes and symptoms there, but changes and symptoms all throughout the body, because we have estrogen receptors throughout the body.
Exactly.
So the hair, the brain, the skin, the heart, the digestive system, joints, bones, everywhere we have these receptors. So all of these symptoms, thinning of hair, bald patches, that can happen. Brain fog, hot flashes, mood swings, skin dryness, skin itching, generally suddenly getting hives. Pigmentation, that can be an issue. It affects your heart, so sometimes you have palpitations. Heart disease can start around your perimenopausal transition. Joint pains, joint aches or bone aches. Delayed recovery from exercise, that's also a very common symptom that women complain about. Then it could be digestive changes, bloating towards the end of the day. Some food which is, a lot of food allergies suddenly cropping up. Even a lot of other allergies suddenly cropping up, apart from food allergies also. Then there could be vaginal dryness, recurrent UTIs, painful intercourse. All of these symptoms can
blood markers going all
blood
over
markers
the place.
going, and that's a typical thing. And I've been doing the same thing. Why am I report suddenly out of whack?
Exactly.
So they are very confused about all of these things.
Sudden elevation of cholesterol,
exactly, insulin resistance.
That's what I'm seeing with most women my age. Their blood markers are all over the place.
All over the place.
Maybe including mine. I have to do one now. But
And how does this affect that? Because this is a lot to deal with.
Yes.
Which you're probably not prepared for. How does this affect their mental health, their sexual health, and everything around their life?
So it's not just a medical issue anymore. It affects everything. It affects their social life. So there are women who don't want to go out and travel because they have urinary urgency. So they don't know where I can find a washroom. So I don't want to go out. They don't want to go out. They don't feel like socializing with people. They're like, no, I don't want to talk to too many people. Don't want to go to places where I'll have a hot flash. So it's affecting their social life. It's affecting their family life also. So unless and until the people at home know about this perimenopause and the mood swings that she might be going through, it's like you're angry all the time. The husband-wife relationships can suffer. Relationships with kids, because very often it's the woman's menopause and the child's teenage. So it's both of them are having hormonal fluctuations. So it causes a lot of clashes. So it's that. Then I have had people who have left jobs because they thought that, no, I can't take the stress of work.
Yeah,
and leaving jobs at the peak of their careers.
Yes.
So it's very bad. They've worked hard all their life for that, and now suddenly they say, no, it's too much stress. I can't deal with it.
Yeah. Now, so you've spoken about the symptoms, And as I keep saying, this is a phase of our life that we have to embrace.
Yeah.
Right? There's no choice. There is no escaping.
Exactly.
Right? The more help we take, the more graciously we accept it, probably the more easy it is going to be instead of silently suffering. So now from the symptoms, before we get into like nutrition and supplementation, one topic of discussion is HRT, right? Hormone replacement therapy, which most women do not know. And if they know, they only know the wrong stuff about it.
Correct.
So we would love to go deeper into HRT so that everyone hears the positive side of HRT because right now it's all negative.
Yeah.
So please highlight on.
So I'll kind of tell you a small story about HRT, so it's very interesting. So hormones started being used in the US in the 1960s. There was this Dr. Wilson who wrote a book called Feminine Forever. So he said that, hormone menopause is like a hormone deficiency disease. So it has to be treated with hormones. And, you take hormones, you will feel young forever, you will have no problem, your skin will glow, this, that, So a lot of women in the US started using hormones. So around that time, I think 40% women of that age group were on hormonal therapy and they were feeling great with it. Now, they started, after this, they had a very small few studies which were taken up, but there was a huge study which started in 1992. I think that was the time NIH, National Institute of Health in US, it had a female director. So she said, no, we need some research for women. So that study, the WHO, the Women's Health Initiative, that was started in 1992. Huge study, 1 lakh plus women, out of which they studied different ways, nutrition, exercise, this and that. One arm of the study had 26,000 plus women, and that was about the hormonal study. So it was a randomized, double-blind, controlled study, which means that there are two groups which are randomly made, and the one group will be given hormones, one group will be given placebo. And I don't, as an investigator, as a doctor, I don't know which one you are taking. As a patient, I don't know what am I taking.
Correct.
Those groups were made and the women were taking it. Suddenly in 2002, the study was stopped all of a sudden. And before even the report of the study came out, there was a press conference, it was leaked to the press that, hormone therapy is causing breast cancer. So New York Times in that time, there was no Instagram or YouTube or whatever, no social media. Yeah. It came on the front page of New York Times, hormone study on women causing breast cancer. So a front page news like that told, everywhere that, the hormone therapy is causing cancer. So that was the thing which spread everywhere. And you know how it is with news, when there's such a strong negative news, people take it up quickly. There were studies after that which were done. There were, corrections made. We tried to understand, analyze, reanalyze the study. But those changed nuances, those changed perspectives, they didn't reach the patients. What just reached the patients was, or the people, laymen, was that hormone therapy is causing cancer. But after that 2002, press release or whatever, we actually went back and tried to understand what went wrong. So what went wrong, meaning the study was obviously well designed. It was done for the good of women, but there were certain things which went wrong, which now we can correct and which can help us to improve hormone therapy. So the first thing is the age of the women. So the average age of women in the study was 63 years. Which was maybe around 2 decades after their menopause, a long time. Women up to the age of 79 were involved in the study. So the whole age group was,
skewed. That makes sense.
So one was the age group was very high. Second thing was, so when you take an age group that's 63 onwards, or when the average age being 63, a lot of changes have already taken place in the woman's body because of age and because of so many years after menopause. So
exactly.
the results what we're going to get are again going to be age related as well. So one was the age. Second was what kind of hormones that were used. We had synthetic hormones that time. We were using synthetic hormones. So oral synthetic hormones were used for this for the study. Third thing was the selection of women. So they were randomized, yes, but all of them weren't healthy. So some were, they were obese, they had high blood pressure, they were smokers. So it wasn't a healthy population kind of, a very healthy population. Fourth thing is they excluded women who were having symptoms. So this was to basically study the cardiovascular effects and all that, So they excluded women having symptoms because, and the reason was that suppose I'm taking a placebo and I'm having hot flashes, If I'm taking a placebo, I would know that this is a placebo. It's not helping me at all. So I have more likely chance of dropping out of the study because it's not helping me. I don't want to be a part of the study, which is why they actually did not take women who were having symptoms. So asymptomatic women, elder women, given not very healthy, given the synthetic hormones. With that, what did we have? Even what we had was not so bad as it was, actually projected out to be. So, for example, breast cancer. So, they said that there's a 26% increased risk of breast cancer because the hazards ratio is a statistical term which tells us the the effect of a certain thing affecting the women. So, that was 1.26. So, when you say 26%, it seems like a big increase. But what were the actual numbers? 30 women out of 10,000 in the non-hormones group, they got breast cancer. And 38 women out of 10,000 in the hormone wala group, they got breast cancer. So it was only 8 extra women per 10,000.
Got it.
Similarly, for heart disease or heart issues, heart attacks, it was 30 and 37. For the stroke population, it was, I think, 21 and 29. So 21 without hormones, 29 with hormones. So only 9 more, only 7 more, only 8 more. Only thing that they saw was really high was a deep vein thrombosis, a thrombotic episode, in which it was the ratio was 16 to 34. So 16 women in the non-hormonal group and 34 in the hormones group got DVT. So that was the only thing which was on the higher side slightly. But again, that was with older women. Synthetic hormones, oral dosage. If you actually see the other positive sides, colorectal cancer decreased. So there were 6 lesser women who got colorectal cancer. Osteoporosis, again 5 lesser women. So 10 out of the hormone group got osteoporosis, 15 out of the non-hormonal group got osteoporosis. So the actual figures were not such huge numbers, So just 7 more women having heart issues, 8 more women having, and out of how many? Out of 10,000. So actually, if you see statistically also, it is not as significant, So the number doesn't come out significant. But when we say 26% because of that statistical analysis, it sounds like a big figure. Even after the study was completed, they went on with the study. And now we have found out things which can help us to use hormones better. So there was actually a group of women who, so when we give hormones, we give estrogen and progesterone. We give progesterone to protect the uterine lining from overgrowing, the endometrium. There was a group of women who had their uteruses removed for some other reason before that. So, maybe a fibroid, bleeding, whatever.
Many reasons,
Now, that group actually had a decreased risk of breast cancer. This never came out in the public.
So you're saying women who've done hysterectomy?
Who took only estrogen. We didn't give them progesterone.
Okay.
So, only estrogen actually helped to decrease the risk of breast cancer.
Interesting.
So even today we know that if you have taken estrogen, you have a decreased, only estrogen, you have a decreased risk of breast cancer. If you have taken estrogen and if you do get breast cancer, not because of the estrogen, but because of other genetical reasons, whatever, you have a lesser chance of dying from breast cancer. The prognosis is better.
Okay.
So the thing that women are most scared of, breast cancer, that's like the biggest scare that they have.
Correct.
It's not as scary. The reason probably why those women, even those 8 extra women who got breast cancer, was probably their genetic thing.
Could have been something else.
Could have been because they weren't randomized to breast cancer results. That is one thing. Secondly, they were using synthetic hormones. So that synthetic progesterone was probably responsible for breast cancer because the synthetic estrogen didn't increase the risk. Maybe synthetic progesterone would have caused that 8 more women to have breast cancer. And we don't even use those hormones now. We use bioidentical
hormones.
So now for the women today who are listening, right? What do you think about HRT and what are the types and when do you recommend?
Right. So HRT, we know what went wrong there. So if we start HRT earlier, so we say as close to menopause as possible, even in your perimenopause.
Okay, during
with symptoms.
That.
With symptoms. If you are in perimenopause, if you have severe symptoms, you can start HRT at that time.
Okay.
So age is one thing. What kind of hormones we are starting? We are starting the bioidentical hormones, meaning what? These are the hormones which are similar to the hormones in your body. So we have estrogen, estradiol is what we have predominantly. We have progesterone. If we are giving you similar kinds of hormones, the body doesn't recognize this as a foreign body. It it metabolizes it in the same way as your natural hormones.
Correct.
What was used then was synthetic. It was premarine. It was estrogen extracted from the urine of pregnant horses, mares. So pre-marine, that was from the pregnant horses' urine. So it also had other things which probably, it was not
Came
human
in.
estrogen. Now we're using human type of estrogen, similar to our body, same with the progesterone. Plus, we are not always ingesting it. We also have topical applications of estrogen, which again changes the way it is metabolized. So the age is different, the type of hormone is different, the route is different. So it's, and it's helpful. Forget managing symptoms. The risk of osteoporosis goes down, the risk of heart disease goes down, the risk of colon cancer goes down, the risk of dementia goes down. So it's also having many positive effects on the woman apart from just managing her symptoms.
And how do you decide between whether it should be topical or it should be injected?
So usually what we prefer these days is a topical application, because
to start with or only?
No, I would say most women feel good with a topical application. The symptomatic, the improvement is good with topical application. So what happens is when you ingest anything, you know, if I ingest a fruit right now, it's going to go from my intestines to my stomach, etc., to the liver. So where it is broken down. So the metabolism takes place in the liver. So when I take an estrogen tablet, it gets metabolized in the liver. So that metabolism is different from the metabolism that happens if I apply something on my skin. If it's something on my skin, it will first go through the blood to the body. It will work in the body. Then the blood will go through the liver. It's not like it's going to completely bypass the liver. But what we medically call as a first pass metabolism, which happens in the liver, that is bypassed. So the effect on cholesterol, on the effect on other metabolic issues in the body, that is much lesser if you use a topical application.
And is that like
it's a gel.
It's a gel, yeah.
So we also have patches which are not manufactured in India. We can import them from outside. They tend to be a little costlier because they're imported. But if you see the gel that we use, the gel and the cream, it's something easily available, very affordable.
How much does this entire thing typically cost?
So I would say from minimum, because it depends on the dosage, but it would be something from around 800 to maybe maximum, if you have to go on the full dosage and all that, maybe around 2,400 or 2,500
a month.
Per month. So
that's in general, I think people feel that it's going to cost a fortune.
So that's a question which I often get, How much does this cost? Because it's something you want to take for a long time.
Correct.
So if I tell them, it's going to cost 10,000 a month, I mean, a lot of people would think twice about that, right? But if it's like 2,000 a month, it's,
still affordable.
Quite affordable, We go out these days for a dinner and
of course,
we spend more than that at times.
And you would suggest the same type even for women who are suffering a lot with recurring UTIs, vaginal dryness, because nobody talks about, no one is talking about vaginal dryness and recurring UTIs, right? They're just dismissing it.
They're embarrassed to talk about it.
Intercourse becoming really hard. No one wants to talk about it. They may talk to their gynac, but again, not all gynacs, in my opinion, are ready to handle menopausal or perimenopausal cases, right?
So I'll answer both these questions. One is about the vaginal dryness, the recurrent UTIs. Now, what helps there is vaginal estrogen. So we have estriol. So whatever we're applying on this, so we have types, E1, E2, E3, E4.
Correct.
So E3 is what is available as a bioidentical one, which we can use vaginally. We also have a synthetic form of that same estrogen, which again can be applied vaginally. And for these issues, vaginal estrogen works wonders. So not for just this, but for urgency issues, for a lot of leakage issues, which are not very anatomically advanced, estrogen can help you. It improves the blood supply.
If you could just clarify urgency.
Urgency meaning, I need to go to the washroom now. So before I reach the washroom, I've leaked a few drops of urine, or, I just want to go now. That kind of urgency.
Yeah, you can't control.
You can't control your urine.
Yeah, that's correct. So then in that case, the vaginal estrogen
and it's much, much safer. I mean, we've used this for women who are in their 70s and 80s who have been getting recurrent UTIs. Typically the woman comes after going to 2-3 doctors with 2-3 courses of antibiotics done, because she keeps on getting UTIs, urinary tract infections. And then finally she ends up with the gynaec who says, no, it's not an issue of, and she's like, why am I getting so many infections? And the typical thing, I'm not using a toilet outside, washroom outside, so what's happening to me? I drink water. So the reason actually is the decreased blood supply, that the urinary area, the bladder, the urethra, the tube which connects the bladder to the outside, the vagina, all of that area is getting lesser blood supply. So the the tissues are thinning out.
Yeah.
So there's more chance for infection to come in, and the body can't fight that infection. That's why those infections keep coming again and again.
Yeah.
And no antibiotics, just using this vaginal estrogen initially daily, then maybe twice a week or maybe alternate days, it magically makes these women feel good. The UTIs go away, the pain during intercourse, that goes away goes away, the urgency kind of goes away. So all of these issues improve with a vaginal estrogen.
Of course, that needs to be, the dosage and all is something that...
Yeah, I mean, it's always good to... Yeah.
Do you also see, like, especially something like this, if intercourse is becoming harder, do you also see it's just impacting their relationship with their spouses?
It does. Because not everyone understands. See, I mean,
the
not
second part, and that's the reason. That's the reason why I wanted to bring that question. That people need to know about it.
Yes, people need to know about it. The men need to know about it. That yes, she's not just saying no for a just like that.
Yeah.
She's saying no because she's having those issues. She's having pain. She has burning after intercourse. Sometimes UTI start after intercourse.
Yeah.
So it's like a again, one more issue around menopause is decreased libido. So there's decreased libido, and it's causing all these issues after she's had intercourse. So she doesn't want to go through it, right? So that's the reason. But sometimes people don't know about it. So it's, I mean, understanding is one thing, but you understand only if you know, right? If you don't know about it, how will you understand it?
Exactly.
So many men don't know about it.
Yeah.
That's the problem.
Yeah. And which is why I just want to make sure that we cover this part, because I mean, men need to know about this very well.
Yeah. And actually the second part of when you said the gynacs don't know about it. Now, we weren't taught this when we went through our residency or medical education. We typically learn, I would say, 40% through books, which had a chapter on menopause, but 60% through our residency a chapter in the book. And
we spend 1/3 of our lives in this space.
Yes, exactly. And so many chapters on pregnancy, all the rest on pregnancy.
Is that changing though in curriculum?
I don't see any changes coming in. Not yet. No changes in the curriculum. Rather than the curriculum, what should change, See, we learn majority of the things that we do in our practice when we see our seniors doing it in our residencies, That's why we call it a residency. We can kind of stay there and learn what our seniors are doing. How do you manage patients? We've never seen our seniors giving hormones, because all of us have typically come out, 2002, those results came out, WHI. That was a time when we were all either studying or either, doing our residencies. So everybody was, thought that, oh no, it causes cancer, right? These newer things we know from 2019 or 2020 and so on. So till then, we're all finished studying. So unless and until a gynaec actually goes in and learns more about menopause, makes the effort herself or himself, till then and it's not their fault. I mean, they've been taught that way. It's like that.
Do you plan to do some sort of education for gynecologists through your startup?
I would love to.
I think that's needed.
Yeah, 100%. I think so too. And also, first is the doctors, and then all the coaches as well.
Yeah, exactly. Correct.
People every day.
Right.
There's no point in just pushing people, go hard or go home or this and that, and then not, not knowing what the female body is going through.
True.
But before we move into the next segment of the brain, I just quickly wanted to point out about the age, right? So you mentioned, so we said, HRT can be done during the perimenopausal phase. When is a hard stop? Like, let's say you said average age can be 51 to 52.
Yeah.
So how many years after a menopause can I still do HRT?
So right now, what the guidelines say is 10 years after menopause.
Yeah.
So there have been studies after the WHR. There was another study which was done, which studied early versus late intervention with estrogen. So the ones who started it early on, in the study it was 6 years and more than 10, and up to 6 to 10 years. So the ones who started early on, they, of course, symptoms improved. The study also found that it had a positive effect on the cardiovascular health. So for those who started later on, after 10 years, what happened? Did it deteriorate the cardiovascular health, heart health? No, it just did not have any positive, effect. So it's like positive effect, yes or no, but it's no negative effect. So even if you start after 10 years, which the guidelines don't say for yes or now, but if the woman is healthy, see, age is a number, right? It's not, I mean, a 60-year-old woman can be 2, 3, 4 women can be different from each other.
Absolutely.
Yeah. So if you actually want someone to feel better with their symptoms, if you're starting it a little later with the woman being healthy, you can do it. It's not like a big red cross, it's not like an absolute contraindication. But yes, guidelines say up to 10 years after menopause is when you can safely use it and see the positive effects as well.
Yeah, yes or no.
Yeah.
And what is the age when someone should just start being a little more watchful?
I would say 30s, because we've been abusing our bodies till that time, literally. Like you sleep at, and right now everybody is doing that.
By abusing, you mean like you're just focusing on careers, working hard, and
I mean, okay, careers is still one thing, staying up at late at night, eating junk and eating crap and not sleeping enough. You want more time in the day. So what you do is you just cut down the sleeping hours. Compromising your sleep. So all of these things you need to slowly start improving. If you started improving that maybe since you're in your 30s, by the time you reach that menopausal or perimenopausal age, you've actually already ticked one box of the management of menopause, which is lifestyle. And then if that's not helping you, then we always have HRT and medication and supplements that can help you.
Correct. Every time I'm talking and if I'm doing a lengthy conversation, I keep forgetting some words here and there. Yeah. And I know a lot of other women also who go through this. I know this are probably dealing with brain fog.
Yeah.
Some people also think it's dementia onset.
Yeah, directly dementia. They reach up to that.
But like we spoke about estrogen receptors, right? Starting from the brain, and we know how the whole phase and then the menopause can impact your brain health in a large way. Can we please highlight on what we can do?
Yes. So many effects.
What actually happens?
Yeah. So many effects on the brain. Again, the receptors are in the brain, which are not getting estrogen enough. So then you start these typical things. You start forgetting words. I mean, you start forgetting names. That person's face is right in front of my eyes, but I can't remember the name. That kind of things. Those kind of things happen.
Yeah.
Regular usage words is what women sometimes forget. This actually causes such a huge impact. People have kind of been embarrassed at jobs, at interviews, at presentations. People have left jobs because of this, something is happening with me. And the scare, am I getting Alzheimer's? That scare is like really bad. So this is something which one reason why it can happen probably is, again, lifestyle. You aren't sleeping enough, you are too stressed. Yes, it can cause. And once you correct these things, some improvement is seen in your brain health or your memory as well. But again, something that can really improve it, and we've seen dramatic improvements once women start using hormones, that the brain fog goes away. So there's a lot of, so again, brain pay, what all effects we have. One is memory. Second is even the hot flashes, they're coming from the brain. They're not coming from the skin, body, right? Yeah. So those, the temperature regulation center in the hypothalamus, what you call those Kindi neurons and all that, they are getting affected because of less estrogen. So that's causing hot flashes, again, brain effect, memory issues, brain effect, the mood issues, the serotonin is getting affected. So serotonin depends, that's a good, happy hormone that you have. That depends on estrogen. So estrogen goes down, that also goes down. So sleep is affected. People even aren't sleeping well. So sleep is affected. So that, so all of these issues are contributing to whatever brain effects that you're seeing, with the memory, with the hot flashes, with the mood fluctuations and things that you are seeing. And, these, again, when you talk of the mood and the serotonin, a lot of it comes from the gut. 95% comes from the gut. Again, the gut microbiome also changes with menopause. What has been dependent on estrogen. So the gut microbiota, the microbes, the good gut bacteria, they are changing because of less estrogen. The gut microbiome starts getting more and more less diverse. So the serotonin production goes down because of that. And that affects your mood. It causes women to get more angry, more depressed. They're like, someone says something, little bit, a teeny tiny bit. And I'm like, I'm either snapping or I'm crying. All of these kind of things come up with, and that is something which hugely affects a woman's confidence. And, there's a nice term I came across, which is DFLM, don't feel like myself. That's something which I can't explain it to you, right? I can't tell you that something is wrong, but something is affecting me. And this is not how I used to be. And very often when this happens, the first thing people think is, no, I think the work stress was too much. I think my child is not studying well, or bache ka 10th hai, 12th hai, something like that. So it's always attributed to something in their life, and lately attributed to, menopause muscle issues.
Yeah.
That's what happens.
Yeah. And what's the, like a follow-up to that question, what's the correlation between menopause and Alzheimer's? There's a lot of, talk about this on the internet and things.
So it's not directly with Alzheimer's, but the risk of dementia is, or the rate of dementia, it's more common in women than in men. So which is the reason for that is that estrogen decline, which can cause these problems coming up in a woman more often than it happens in men. So these issues, dementia, even your osteoporosis, it's like 3 times more common in women than men. And the difference here is because of the hormones. Of course, Alzheimer's it's not like a direct causation with menopause, but it's related to it.
So can I say that some of the solution here can be HRT, exercise, nutrition, weight training,
sleeping well, just sleeping. And again, it's easy to say for me, you sleep well, but the lady's telling me, Madam, neend nahi aata hai. What do I do? That's the problem. So again, here HRT helps. Sometimes progesterone is the second hormone that we give. That dramatically improves sleep. She sleeps like a baby after she takes that. Sometimes supplements are helpful. Magnesium glycinate as a supplement, that can dramatically improve your sleep. And if you see, if you're not sleeping, your brain is not resting. You can't overdose, keep on overdosing your brain. Already it's dealing with so much information. Too much stimulation right now. So it needs to rest.
It's also our, I was just mentioning to you that I was in Ladakh recently, and the sunrise happens quite fast, like quite early, as in 4:30. It's proper sun. You don't have like to blackout curtains and things are in there, so you wake up with sunlight. There is not much light after it's dark. So 1 week I was there, and within just that 1 week, my sleep cycle was so much better. My stomach, the quality of stomach emptying was so much better. I'm not kidding. I didn't have coffee the entire 7 days. I'm drinking a lot of coffee.
Wow.
I didn't have coffee because I didn't feel like that I need coffee to like show up and do things.
I'm surprised you didn't have coffee.
No, because I was riding like 10 hours a day, and I didn't want my stomach empty to get disturbed. It was going completely fine. So my point is that, do you think that this
circadian rhythm is so important? Because these days, I mean, again, most of the women tell me they can't sleep. I say, what do you do if you can't sleep? Oh, I look at the phone, because how else would I sleep? And when I tell them, leave the phone aside, when you go to sleep, then how will I sleep? It's like literally something that's putting them to sleep, but it's putting your eyes to sleep. It's actually stimulating your brain. Then there are people who say, I sleep at 1 o'clock, but I get my sleep, doctor. I wake up at 10 o'clock. But your body is not following that circadian rhythm. It has to, whatever has been told in our age-old, traditions, religion, it's for a reason. So, I mean, they attribute it to God, but it's for our health, that you eat early, you sleep early, you wake up early, and your day is good. Your day is really good if you follow the nature's rhythm.
But otherwise also, if like someone's not doom scrolling and things, there is otherwise also a lot of light. We live in a society that is deprived of darkness.
True.
Do you think things like the blue light blockers and all of that is helpful?
I guess so, yes. But I mean, rather than blocking the blue light, block the device first. That's
the biggest impact.
Yeah, that's the biggest impact,
Yeah, makes sense.
Stupid question, but what are your thoughts on all these brain activities or games? Let's say adult Lego or mandala drawing. I've been doing these things.
Yes, it's really helpful. Typically, if you go out right now and see people sitting on maybe a bus stop, if you saw this like 20 years ago, they would be sitting and, just staring into space, looking at the leaves of a tree or whatever. Now everybody's like in the phone.
It's crazy.
It's crazy. So we don't have that empty time, that time when we are, relaxing, or we are giving brain some time to recuperate, and or else, arey wo movie ka naam kya tha? 1 sec, let me Google it. We're not giving our brain a chance to think about it, So if you're doing a puzzle, your brain is actually doing some thinking. And it's really helpful. So all of this is one major thing. I mean, there's no medication to improve. I mean, of course, apart from HRT, there's no medication. Ki, acha, ye tablet lo, then you will remember everything. But then these things are really helpful. When you're doing a mandala drawing.
I'm going to continue.
Yes, please do. It's really nice.
My mother does for like last many years. She does pottery. Pottery is something that she does the entire day. But the Sudoku in the newspaper.
Yeah, my mom also.
Without that, her day just won't start.
Yes, that's what I Sudoku, all those puzzles, those crossword puzzles.
They're pretty amazing.
Yeah. And she has to solve them. It's like a part of it's a routine in her day. It's like that.
Yeah.
Okay.
So before we get it to closing, right? We spoke so much about HRT. Now, of course, there will be women who will be completely no to HRT, against HRT.
Yeah.
Let's
Unfortunately.
would you be able to help us get a little more information on how maybe just nutrition and right supplementation can, not in
Yes,
detail, maybe,
yes,
but
yes.
maybe for such women.
So
it can
so when we take HRT, we are taking estrogen and progesterone. So we can also take some of these hormones. Of course, they will not be completely equivalent to the estrogen we are taking, but we do have plant phytoestrogens, plant estrogens, which come in a lot of plants. Like we have your soybeans and tofu and sesame seeds, all the other pumpkin seeds and so on. All the lentils and dals, all the fruits. So apples and berries have phytoestrogens. So basically, including all of these different kinds of seeds and fruits and things in your diet, that itself can give you some of the much needed phytoestrogens, which if your symptoms are mild, they can definitely help you. They can support you. They can help you, along with a good exercise routine. You're sleeping well, and you're doing some mandala drawings.
Yeah, and anything on supplementation?
Supplements, what I would say is, of course, it depends on your blood reports. Suppose vitamin D is something very commonly people are deficient in, not just women. B12 deficiency is common among vegetarians. So that depends on your reports. One other things that you can otherwise also take, I think one is protein. So protein as a supplement, you can look at it as a supplement or look at it as food. So for vegetarians, I often say that go for an extra supplement as in a protein powder. You can go for a plant-based protein powder also. Something other than that which can be helpful is one is creatine. It's helping not just your energy levels, but also your brain, this thing. So it's good for your brain as well. Another thing that I often recommend is omega-3, because the ratio is quite skewed in our diets right now.
Yeah.
With the oils, etc. So these are few supplements which can definitely help quite a lot. Magnesium for sleep, that is something that can be really helpful. Calcium, if you're not having enough from your diet. But again, calcium, one common mistake that people make is that they start calcium after menopause. So the calcium absorption, it depends on estrogen. So when you don't have estrogen, the calcium won't get absorbed. And then they say, no, calcium makes me have kidney stones. That's because it's not getting absorbed. So you need to take it, build up on your bone strength before you reach menopause.
Got it.
Then it's helpful.
Okay. We spoke a lot about estrogen. I just had a quick question on, almost nobody in India would be prescribing testosterone to women. Should they be, and how does it help?
So, if you look at estrogen, progesterone and testosterone. So, estrogen, progesterone typically dip down quite a lot around menopause because they're coming mainly from the ovary. Testosterone is also coming from the adrenals, and there's an interconversion of estrogen, testosterone with each other. So, adrenals still are giving you testosterone, but yes, the levels go down with age. So, sometimes when women have symptoms like a lot of tiredness or, again, brain fog also sometimes it helps with testosterone. So in these women, we can use testosterone. The problem with it is that there is no approved medication of testosterone for women. So whatever is there, medicine has always, it's always favored men. So all the research, everything on men, So testosterone, whatever formulations we have available in the world, or at least in India, they are all for men. So we don't have a female formulation. So we have to titrate the dose and decrease the dose when we want to use it for a woman. So that's again a little nuanced thing which people, even doctors, all of them don't know about. Again, same reason, we haven't been. If we have one chapter on menopause, we have no chapter on testosterone in women. We have not been taught about it at all. This is something which we know now.
Yeah. And how is this in countries like the US and all?
I think there is a formulation which is there for women. I'm not sure. Maybe in Australia and the US or UK, they have a specific this thing for women. But again, I mean, FDA doesn't approve testosterone in women. So, but there is some country, I think Australia, I'm not very sure, but they have this thing for women. Otherwise, we have to kind of titrate it and use it. So make it into parts and use only 1 ml of it, and all of that we have to use. Again, we can use it as a gel. Typically, what we use is a gel, or rarely as injections once a month, but mostly as a gel is what we use it.
Understood.
So if every Indian woman over 40 is listening to this podcast now, what is the single most thing that you would tell them to?
I would say don't be scared of hormones. It's not like
Thank
a
you.
demon that it's meant to, it's supposed to be meant to be. It's not out there to, destroy your lives. It's actually there to improve your
Support
support
life,
us and give us a
100%.
better quality of life. That's something I would definitely want to tell women, because we are past that thing where we say be aware of menopause. Yes, now somebody who's watching it, I'm sure, is aware of menopause, but now go take that step further than that. Yes, you know your symptoms, what menopause is coming with for you. Now go for the management of it and don't be scared of hormones.
Exactly.
You can
Yeah.
use them, they can be
I
helpful.
think it's 100%. I would
Yeah.
say the same thing, that
Don't
you know what
walk
your
away.
hormones can do for you. It is what I keep saying, telling a lot of the women, the younger women, I said, treat your period as your report card.
Yeah,
the monthly report card,
that's
right?
so nice.
I said, which men don't have the privilege of, but we do.
Right.
And if you're tracking that, is great.
Yeah.
Your health will be great.
Right.
So embrace.
So sometimes women come and say that periods are called with different names, chums and this and that.
Yeah.
So problem nahi aaya is mahine. मतलब problem nahi aaya, ye problem hai ki, I mean,
Yeah.
why are you calling it a problem? It's a period. It's something that it's not a problem.
It shouldn't be.
Yeah.
If it is, then there is a
हाँ, nahi aaya problem to problem hai. It's like that,
Yeah.
Amazing.
Okay.
Yeah.
If someone has to reach out to you, how do they do it?
Yeah, we can list
We'll
it in,
link it.
and
Yeah.
I'm there on Instagram. I have a few videos on YouTube as well.
We'll link all of that.
We
in
can
the-
also leave a cheat sheet.
Yeah.
With
Yeah,
some do's and don'ts.
Definitely.
At
That'll be
like at a HRT level more than anything else.
Yes.
Yeah.
What do you think?
Yeah, we should definitely. We'll
With doctors.
yeah, we'll drop a cheat sheet here.
Yes, will be very
Anything
helpful.
that prior to getting a consultation, anything that they need to be
Yeah, so
watchful for,
a
be
basic
prepped for.
set of we don't need hormonal tests all the time.
Exactly.
That's again an important point, that you don't need to check your hormones before you start hormones. Your symptoms are enough. We're not treating that piece of paper. We're treating you as a patient. So your symptoms, your age is enough for us to understand that yes, you're in a perimenopause. We don't need to do your hormonal levels to find that out. But yes, we need some basic tests. If your liver is doing fine, because it will be metabolizing your hormones. If your cholesterol is fine, where's your sugar? How are your sugar levels? How is your thyroid? Your vitamin D, vitamin B12? Because the symptoms of these issues can mimic the symptoms of menopause as well. So understanding how those blood parameters are, getting a basic ultrasound, getting a mammography, a pap smear, all of these are basic things which we want to get done.
Correct.
Even if you don't want to take hormones, you still need to do these things once a year. It's like that.
So this abrupt marker of fatty liver for a woman, that is also
yes, it comes up because of
the liver.
Again, it's a combination of your lifestyle and your this thing.
Amazing.
Menopause.
Okay.
This was fun.
Thank you very much.
Thank you so much.
It was lovely being here and talking to you guys.